So my name is Neil Brown. As I was mentioning, I am the director of business development for Samsung, and I basically manage the Sonio, which is a women's health imaging and reporting solutions, kind of a PAC system essentially. So just like you deal with large X-ray or CT PAC systems, this is specifically for women's health, for ultrasound specifically. And it worked perfectly. So basically, we want to talk today about AI and the importance of AI, how it's impacting women's health from an ultrasound perspective, as well as how its adoption could be a little bit limited in how people adopt it, either from the sonographer and from the reader. The difference is most AI right now, especially from an X-ray, is more or from CT or for MR or even breast X-ray, is mostly impacting the reader. However, in women's health, it's impacting the ultrasound tech directly because it could be on the ultrasound system. A lot of the AI is driven on the ultrasound, and then from there, it's now driven in our imaging and reporting platform, where it can do some efficiencies, which I'll get into and explain. The goal is basically to streamline workflows, support medical training, and provide data-driven insights for decision making. And again, like I was saying, the offers many advantages, but however, there's challenges such as trust, regulatory concerns, and data reliability. Those are the main constraints. Right now, AI-powered algorithms are being developed and deployed. They assist in real-time ultrasound image acquisition, which is pretty interesting. So as there's one of the Samsung products that we have are ultrasound systems, you can scan the baby from head to toe, and it'll just automatically start extracting images and annotating them automatically for them. AI is also improving standardization, reading standardization for the reader, as well as providing diagnostic confidence. So now we can recognize pathology within the fetuses. And so studies have indicated that AI can help identify specific fetal anomalies like congenital heart defects, neural tube defects, or even fetal growth restriction. And so AI-powered features are assisting, like I said, capturing better images, making decisions faster for the reader and for the interpreter. A lot of them are MFM doctors who are specialized in reading, or even in a radiology department, maybe a radiologist, right? So AI is already in use in prenatal care. We've been on the market for already 2 years. So we've been out there and people have been using and utilizing our AI, as well as there's other AI, other competitors out there, and they provide different variations. The why behind AI, I think this is really important. This is kind of like our mission, our driven mission, essentially. So why is AI so important in ultrasound? Very technical, it's very technical driven from an ultrasound perspective. The tech is really the one that's kind of the operator, manual operator, helping the eyes and being the eyes for the physician. So right now, if you look, about 10 to 30% of all critical defects are detected late, 3 days after birth. So that's a significant impact. Or 39 to 56% of major heart defects are missed by scans, by normal scans at 20 weeks. And there are some critical congenital heart defects like coarctations, tetralogy of flow. And on average, nationally, about 100 to 200 newborns die in the US each year because of unrecognized heart disease, and that's after birth usually. Why cases are missed? Some technical limitations, right? You can have high BMI patients, you can have maybe the baby's fetal eye, certain things like that. But then, the detect was not visible, maybe due to inadequate imaging, bad technique, bad form, maybe mom wasn't compliant or whatever have you. Poor adaptation skills, how to help the mom, maybe roll on her side or things like that during the scan. And then also recognition errors. The tech, in 31% of the cases that were missed, the defect was actually visible. So they did a 4-chamber heart, and it was normal by look, but they didn't look at other areas like the aorta, and they missed that coarctation. So just not recognizing, or maybe it was total anomalous pulmonary vein return that is hidden if you don't know how to look for it, depending on the gestation of the fetus. It could be obscured and they don't know how to obtain that image. Complex anatomy, and that's probably the total anomalous pulmonary vein return. That's the probably inevitable misses because the anatomy appears normal, but it's a odd defect, right? So if you're not experienced in it, you can miss it. So here's some opportunities within AI. Right now, from an AI perspective, we can increase workflow efficiencies. We can auto-generate the reports based off of what was imaged from a view perspective or a structure perspective. We can recognize structures. So if you take a 4-chamber heart or even the abdominal circumference, we can tell you what structures within that view are missing. Maybe you're off axis or something to that effect. And we can prompt the sonographer that, hey, we didn't verify that. We didn't verify the umbilical vein. And if we're looking at the heart, we didn't verify that the mitral and tricuspid valve were there or present. And basically helping them be more efficient in their scanning and having to prevent rescans down the road. The patient may not have to come back if they can be told, hey, get a better image and, or fix this image, you're missing this. And then you'll have more exam completeness, basically. We can evaluate those images and we can look at the measurements that come across. And so we'll populate all that information on the report. What was visualized, what was not visualized. If this measurement, like an AFI, was obtained, we can say, hey, this is normal, this is oligo, this is palate. And physicians and however they're practicing can set those ranges for normal or abnormal within their practice. Same thing for heart Z-scores. If you're Z-scores of the heart inside the heart, we can tell you if it's abnormal or normal and automatically populate that on the report. And the goal is to reduce risk, because instead of dropping the default normal report, or maybe you're busy and you're trying to dictate a report, it's at least giving you those prompts of what was visualized and what was not visualized, or what was normal and what was not normal. So they're getting instant feedback, basically to help improve the quality of the imaging and also the reporting. And ultimate goal is and what we're seeing across the US is that a lot of ultrasound departments don't have a continuous quality improvement program. They usually are very reactive for accreditation, like ACR or for AIUM, and they only are doing it maybe once every 3 years, where if you have continuous AI evaluating it, you have a continuous quality program. And people don't do it because it's a resource dependency, right? If you don't have somebody to constantly look at images or look at protocols and look at reports and do this, we're all so busy and we're also limited on resources. That's where AI can provide the best efficiency and help in that aspect. And the ultimate goal is, right, enhance patient care, right? So if we don't have to bring the mom back, we can get a full complete exam that first time, or at least majority of that exam the first time, or even identify if there's a pathology, then we're improving outcomes, right? Diagnostic accuracy with AI. So as I was talking about, fetal detections of abnormalities. So you have your congenital hearts, neural tube defects, anything that's going on that's abnormal within the baby, fetal growth restrictions we can pick up. Even placental issues, that's what we're working on. Even like for placenta accreta, that's one thing that our AI, we're working on to try to help reduce and improve the mortality of moms have, placenta accreta issues. I think 100 moms die a year with placenta accreta or something. So something that we can help with. So basically the goal in that is we want to improve the scan times and read times. As I mentioned earlier, the why behind AI, we miss almost 50% of any pathology that is out there. So if we can bridge that gap and improve, and catch those abnormalities ahead of time, then it's a win-win situation for everybody. And I think they determined that, and they found that out in breast ultrasound. And I think I'll have an explanation on that coming up pretty soon. So, enriching the diagnostic accuracy by imaging, but also reporting. So if you have a default normal report, if you drop a normal report, you may forget something. But if you have AI as a co-pilot, maybe it's reminding you, hey, this is what we saw in this image, or hey, this is what you documented on the last report, and now it's different, or whatever have you. You're improving that reporting accuracy to help reduce risk. And so, for instance, for the neurotube defects, the sensitivity rate and specificity rate was 96% in detecting neurotube defects. That's one of our algorithms running on the brain. We can recognize the ventricles, all the different structures within the brain, and identify that. We're doing a study on CMV, and we're realizing that we're picking up CMV cases people don't even know. It's like it's hard to see, but the CMV is there based off a certain, when you're sweeping through the brain, we can pick it up automatically, and it can alert the tech. So AI as a training tool. So that's another important thing. I think that's the biggest one. There's a big skill gap from somebody that comes out of school versus somebody that's experienced, right? So they have more than 5 years of experience, and they're fine. They know the protocols. They know what to do. They're used. They've been trained. But somebody out of school, how do you get them up to par faster, right? So if we have a standardized protocol that says, hey, you need to capture X, Y, and Z, a list of stuff that needs to be done, and then we're helping them identify structure abnormalities or any defects within the baby, we're helping to upskill them faster and get them out there and get them autonomous, get them comfortable, and they don't have to have somebody hovering over their back, kind of watching how to scan or do things like that. So it gives them guidance, helps them complete exams faster, helps them obtain high quality scans, and some of our analytics, we can even provide a report card to the sonographers and say, hey, you're consistently missing maybe a 3-vessel view on your exams. It'll remind them, okay, and I need to go back and start making sure that I capture a 3-vessel view. And so that's the beauty of the AI, because it can evaluate performance and help keep that sonographer growing in their skill and subset. Virtual assistants and simulations, as I was mentioning earlier. So virtual assistants, like we have made co-pilots or AI bots, they can be within our systems to basically help tell you, hey, you know, this number seems abnormal, or this, you know, let me help you complete the report, or suggest this impression, or suggest this macro, or suggest this template. Those are there for basically to help them, you know, make it more efficient from a report perspective. So this is an example of everything that a sonographer has to obtain for a detailed 76811 exam. This is a comprehensive detailed exam. So it's nice that you can have some type of, especially if you have an abnormal patient or somebody that's complex, you may start scanning, then you get tunnel vision and you forget where you left off at, right? So AI can help provide a better checklist and check off, as well as quality of those images to help you provide that complete exam. And so this is an AIUM protocol. ACR, I think, has a little bit of a different one, but this is an AIUM comprehensive detailed protocol. It basically just helps, like I said, upskill the sonographers, help them make sure that they have the right structures obtained for the physician that's reading them. Some barriers. So what we've learned across the way is that everybody practices differently, outpatient, inpatient. So how we set up an outpatient may differ from how we set up an inpatient. Outpatient facilities don't like, so those tablets can be mounted on the side of the ultrasound system, obtaining real-time imaging. We're a cloud-based application. So images come up, AI evaluates it, and it prompts the sonographers. The outpatient ones are more, the sonographers are like, I don't want that on my machine. I don't have that, you know, or I don't trust the AI to that effect. You know, I know what I'm doing. I've been scanning for 20 years. I don't need to have an AI tell me what to do. But where in a hospital, those mounts on the side, if you have the infrastructure and those mounts on the side with the tablets, images are coming up and they're going straight into the cloud and they're sent on the tablet that the sonographer can see, they can quickly grab initial images, they can complete their report at the bedside, and it goes straight to the radiologist or to the reading physician. So it's just adapting, doing the workflow, and then that's a good important point is you really want to know every AI could be a little bit different. You have ambient listening and you have AI features from an imaging perspective. So dictation, AI versus image recognition, things like that. So it's important that if your vet AI within your institution, know what that AI does and how it's going to impact the workflow, and then who it impacts on the workflow. Because that's how you're going to kind of vet to know, okay, what's the impact? What's the barriers that we're going to face? What's the adoption? How do we make it adopted, right? And that's where governance comes into play. Because then you have leadership that says, okay, I'm the key stakeholder. I'm going to help sonographers adopt this. This is the workflow we're going to implement, and we're going to ease them into it and understand it. And that's how what we've learned from a training perspective is we don't turn the AI on day one. We evaluate how they're scanning. We evaluate how they're using their day-to-day end workflows. And then we start trickling it in. We start turning it on little by little, by structure, or whatever have you. And we come up with a plan with the customers. So, job security, a lot of them are afraid, hey, it's going to replace me. No, it's not going to replace you today. Maybe in 10, 20 years, but I don't think it will replace you. It's a tool. It's an added tool. It's a tool in your tool belt to kind of help you, like I said, to help upskill you, you know, help get you, help provide better patient outcomes, help provide, you know, just give you that confidence, help make you more efficient and more effective for the physician as a sonographer. There you go. As I was talking about breast ultrasounds, you know, AI-assisted interpretation of breast ultrasounds has decreased false positives by a rate of 37%, leading to a 27% reduction in unnecessary biopsies. So having that alert of pathology, you know, I think that's 40% bridge right there, almost a gap. So if we can recognize fetal congenital heart abnormalities or any abnormalities within the fetus, I think we can cover that gap and bridge it and help provide better outcomes. We can treat a lot of things nowadays. Palliative care. We can keep patients alive. You know, I know single ventricle patients that are alive post-delivery that are in their 30s now. So we have the technology. Some adoption barriers, additionally, are regulatory and ethical concerns. So, right. So if you look at regulations, so if you're going to vet a vendor, my suggestion is look at how are they FDA approved. FDA approval is no joke. It takes a long time, so they should have an FDA approval. We have quite a few FDA approvals within our organization for our AI. It takes 5 to 6 months, but because we're AI, it adds another year, almost 300 days to get things done. So it's a long time. Yeah, no.
First of all, what you're presenting is actually a really good use case for AI.
Mm-hmm.
They're on the average sonographer to be great.
Yeah.
But you're correct with trying to get something AI through the FDA.
Mm-hmm.
And that's what I am curious. It's not just that time.
Mm-hmm.
It's the training that went in and then the validation.
Got it.
For all the different physical phenotypes. I can't even, I'm dealing with this in cardiac.
Okay.
I can't even imagine in prenatal.
Yeah.
Variations.
Collect. It's so big. Yeah.
You guys did a tremendous year.
Yeah.
Millions can understand.
Yeah. Yeah, exactly. And then, well, I mean, and to get the data sets, right? So you have to find all that data and variations in data. And I think data integrity is important from an AI perspective, because you don't want just I only want the best ultrasound systems that I'm going to train my AI on. No, you want a large variety of different types of ultrasound systems to train your AI on. That way, because every pixel is a little bit different, how people scan is a little bit different, and then also BMI. Patient variation in BMI, and even technique. You want to train your AI and all that for better accuracy. Yeah.
You guys, you have actually 2 different patients.
Mm-hmm. Yeah, for sure.
Again, your use case is great. I love it.
Thank you.
It really is quite brilliant.
Appreciate it.
Is this local or in the cloud?
It's in the cloud. So we're managed service. So we're a SaaS solution in the cloud. And so basically it takes all the infrastructure off the hospitals or the facilities. For outpatients is great because it's just a subscription base, and then same thing for the institutions. They don't have to worry about the cybersecurity. They're only connected to us through a VPN, and that's the data security, privacy, things like that. Cybersecurity piece is we're only connected through a VPN. So if you get breached or I get breached, we just cut that VPN. And that's the other thing is ask your vendors, are they SOC 2 type 2 secure? We're the only high trust certified. So most EHRs are high trust validated for their data. So we're the only PAC system out there that's high trust. So the version that we have out right now recognizes a number of structures, a number of views, a number of pathology. So we had to clear all those. So the structures and the views had to be sent to the FDA, get cleared, and that was a long time process. We had to have, there's like a reader and annotator process, so many years of that, looking through millions of images and then submitting that and then feeding the AI. That version was cleared by the FDA. Any new versions have to go right back to the FDA. So now we have another subset of structures. So based off the number of structures that we can recognize today, we want to bridge that gap and make it the entire body, at least from the ultrasound perspective, right? From especially fetal and maternal. And so we submitted a whole nother set of structures that we can recognize, and that was a whole nother process. Same thing for pathology. We submitted a whole nother thing for pathology recognition. And again, that's another subset of images, we have to find all those pathology cases, and then they require you to have specific amount of pathology to detect. They don't just validate you off of, oh, you have 10 studies. No, it's hundreds of studies that we have to. We have a great team. Uh-huh. Yeah. Yeah.
If you have a PhD that centers on AI,
mm-hmm.
the day you get out of college,
yeah,
you can easily get a job at 40 a year.
Yeah.
With $500,000 to $1 million someone.
Oh, for sure, easily. I believe it. I believe it. So yeah. So to your point, every new submission. So once we push that version to production, there's no changes within that. So when whatever you're using what was trained, what was evaluated, and what is clear to be used on humans, essentially. Mm-hmm. No, it's software. So it's us. Yeah. So because it goes to us, we have kind of like an AI brain, an AI engine in the back end of our solution. And that's basically what runs all of our algorithms, and it's homegrown. And so that's another thing to ask is, are you a homegrown AI? Or are you off the back of something else, a third-party AI? So we're homegrown AI. And so our engineers, data scientists have to go in. If there's something that's off or skewed, then they go into the data and they say, okay, let's just make this little variation, or let's make this tweak or adjustment, So, but yeah, no, it's huge. So, so ensuring robust, again, just that the data is paramount. So we have to protect data too. That's another piece of it all. So whatever data that we train our AI on has to be anonymized. And so it's just not removing the name tape on the front of the image. There's metadata on the back end. We have to scrub all of that information. You can retain and calculate an age, maybe even ethnicity, if there's an ethnicity and within the images, but everything else has to be scrubbed from a PHI perspective. So things to ask about how people train their AIs is very important. So. In conclusion here, so we can revolutionize the ultrasound industry. I think we can bridge the gap on identifying pathologies that are missed today. It definitely will improve efficiency, give some work-life balance back to the physicians and sonographers, enhancing diagnostic accuracy and clinical decision making. The keys are to make sure that you have a plan in place for physician and sonographer adoption, know the workflows and who it impacts, the AI that you're evaluating, and then of course trust data diversity, as we were talking about, making sure that the AI was trained on large data set models. And then of course the accuracy within it. They should have some type of accuracy that was validated and submitted to the FDA that shows, hey, I'm 97% or 96% specificity or sensitivity within this structure or view. So, and then also that the vendor meets AI regulations within the US. So FDA clearance, things like that, SOC 2 Type 2 if they're a managed system, things like that. So we can overcome these barriers and we can pave the way to become trusted and an indispensable tool in OB and maternal fetal medicine. Adoption of AI can improve image quality, capture, as well as reporting accuracy and optimized workflows, leading to improved efficiencies, quality control, and standardization. That's key standardization, making sure that you're meeting within standards, your accreditation standards, setting that bar a little bit higher. And then more importantly, reducing risk for the patient, risk for the physicians, sonographers, and the institutions, but ultimately improve patient care and outcomes.
You guys could provide a QC scan. So you have a known structures. And now you can actually use that for training, sure. But you can also let people know if they do this QC scan once a week, if there's something wrong with the machine,
yeah,
you're going to work.
Oh yeah, for sure. Yeah.
Roads go bad. They trip.
Yeah. Yeah.
So that's another service that would be incredibly well suited.
Yeah.
And very easy to add.
For sure. Yeah, because they have those. They have those pregnancy models, those silicone pregnancy models that people scan on, just normal fetal anatomy. But to your point, I think they can throw in some abnormalities, things like that. Check for defects, making sure that the AI within the machine or the AI within the PAC system is working appropriately. So that's a great point. I like it.
It is fascinating to me. Like I'm doing AI.
Okay.
And I'm seeing what it's doing there. It doesn't, at this time, none of it can replace humans.
That's for sure.
They made it. But at the same token, it allows, and I have a mixed feeling with this. The whole concept from the cardiology and also from intra-op stuff to this, it allows the average person to be great.
Yeah, agree. I think that.
Then does that mean they're going to wake up a whole bunch of average people and nobody?
Well, does it? I agree with you. I think that does it mask skill sets or growth? So does it? Oh, and they become more button pushers essentially.
This has to be addressed in your FDA submission.
Yeah.
It's one of the requirements. The FDA wants to know, what are you doing to ensure that there's not an over-reliance of the AI? That has to, your developers have to build that in, because it is a concern.
And I think that's where AI is not definitive and says, hey, no, this is this. It requires that the physician, it's all suggestive AI. Can the sonographers, like I think I had a slide on there that said, let's see if I go back, or even this one right here, missed views, you can clearly see, clear for the scan, right? We can clear it. It's just suggestive. You can override it at any time. Same thing for this one right here. Not verified. You can just click on not verified. So no, I saw it on a cine clip. I verified it. So you can override and overrule it. It's more suggestive, and I think that's where the FDA, that's where they're looking for. They're making sure that it's not set in stone. That your AI is forcing it and cramming it down the physician that says no, it's only this, and you can only select this. So and I think that's a key component that you have to, when you evaluate AI, is that making sure you still have the ultimate rule over it. So.
And make sure that the radiologist has the information.
Got it.
Once the images are required, it takes long.
Yeah.
And if something's missing,
it's missed.
The patient workflow, I guess the only real
Yeah. Yeah. Well, and that's where and I think from cardiac, I think cardiac and breast have a AI component bill that they can bill, but maternal, and that's one thing you have to get like a Cat 3 CPT code and then a Cat 1. It takes years to get a Cat 1. So I guess that's the next evolution from a reimbursement perspective. Do you get reimbursed for AI? But so far what we've discovered is like what's in the codes, they won't accept any additional AI because it's the evaluation of the interpreter, how it's written on that CPT code. So maybe if we legislate for it and things like that, then you have to have a lot of it.
So you want to bring something like this to market. You'll spend 2 or 3 years in development and experience.
Mm-hmm.
You have to have true science.
Mm-hmm.
You're writing paper. Those people are getting paid $200,000, $300,000, $400,000 a year.
Mm-hmm.
For a couple of years before you ever bring something to market.
Yeah.
And then when you do bring it to market, the company says, oh yeah, $35 a shot. And the two don't add up.
Yeah. Sure. That's for sure. Exactly.
You're
Yeah.
operating in other countries.
We were, but we decided to take a step and focus on US because it's more of a diverse workflow where like if you go overseas, like in the EU, so not, the physicians are scanning there. And so that's where you saw like on the one that I had, the tablet on the outside of the machines. This is a physician, he's scanning, it's alerting him right then and there. It's a little different workflow in the US, you know, and like I was talking about adoption earlier, the, you know, outpatient may not be so keen to doing that, but inpatient is. They want that monitor on that side is what we've realized. But so we have a little bit of diversity within that workflow. We kind of recognize that. And so once everything is good within the US, then we're going to focus resources outside of the US. So.
Europe can be a tough market. Generally speaking, the French only buy things that are made or developed in France.
Yep.
The Germans, etc.
Exactly. Yeah.
Americans don't care what I was worth.
Yeah. Exactly. Mac bid. Let's do it.
Thinking this, I'm bored actually. The main reason why I'm sitting here is AI.
Sure.
$4 and 9 grandkids. So the whole prenatal thing.
Yeah.
For most of my life. In the X-ray world, one of the advantages we have is a lot of this stuff is being used in India and China.
Yeah.
So the data sets are volumes.
Mm-hmm.
It's strange, and I've got to say, it was the FDA that educated me. Just on the heart alone,
yeah,
there are differences between nationalities, races, and our data set had to include all these differences. And it's easier if you're in China because they're so homogenous. But in the US, even look at this room, right? The US is this wonderful hodgepodge of nationalities, races. But the burden on this stuff,
to train it. Exactly. Exactly. So every market you hit, you probably need a data set associated with that. And then even like with the AI that's built on the machines that are auto measuring, for years, we measure our own biometries manually, but now the machines are doing it for you. And so and there's authors behind those measurements and those calculations to kind of change those calculations and make the dating a little bit more, it's either going to make it more accurate or they're going to have to write research papers to determine how accurate it actually is. So I think there's some stuff to be done. So.
For me, that's fascinating. We're developing AI systems things related to politics.
Yeah.
And one of the things that we discovered as we went through every product in the market is actually very inaccurate.
That's interesting.
And then when we delved deeper, we discovered there's almost no way to get accurate measurements.
Wow.
It's like a 10 variable equation.
Wow.
Ultrasound is very different than X-ray.
Uh-huh.
Ultrasound can get it back.
Mm-hmm.
It has enough data to solve that equation.
Yeah.
Can't do what X-ray does.
Yeah.
But X-ray can do what it does.
Yeah. Yeah. Well, I mean, if you look at the gestational EFW, that's why there's always that plus or minus 2 to 3 weeks. So maybe now, from a I mean, most pregnancies go off of the crown rump length on the first trimester, and that's what they usually trended off of for EDD. But then, maybe mom doesn't have the care, early trimester, so they're measuring second or third trimester. A lot of them don't come into care until third trimester, so you have to do your measurements. So it's always plus or minus 3 weeks based off of the current calculations. So now maybe those use cases, maybe it'll bridge those gaps on the accuracy perspective. So yeah.
I do apologize.
No worries. I hear you. That's important. Yeah.
I'm sure that was
Yeah. No, so our imaging reporting solution is Sonio, and we're a company of Samsung. Yeah. So yeah. So we were, and actually we're a French company. So our AI originated in Paris, and so and then of course with Samsung being in Korea, South Korea, and Seoul, so they basically purchased us, and so now we're part of them. So now we have, of course, global. So that's the goal. It's global.
this is incompatible with any ultrasound, or do you have a list of ultrasound testing?
Any ultrasound. So DICOM is DICOM. So any image acquired by an ultrasound system, we can evaluate it. It's just DICOM data.
We did have to push back on the FDA with the cardiac, because they said, okay, you acquire data on Philips and Siemens. So how do you know about Shiva,
Canon, and all that other stuff? Yeah.
We had to go back. Sometimes the FDA is wrong.
Yeah.
And we actually had 2 opportunities
Yeah.
to actually prove them wrong.
Nice.
And one was on a conference call with them.
Oh, wow.
The cardiac for the stenosis. They wanted to have 10%. And my business partner, PhD nuclear physicist, and they had all their experts. And he was like, you do know that you can't do that. I'm like, oh, no, this is a requirement. And every company do this. Well, have they complied? Yes. And they lied to you. Like, what do you mean? As you explained how in the image, for cardiac stenosis measurements, you cannot get more accurate than plus minus 25%.
Yeah.
And they were stunned.
They're stunned by it.
We're going to discuss what the requirements are to get that.
You don't get that often. That's good. That's awesome. Yeah. So yeah, no, I think the FDA is definitely a hurdle, and I know we had to have some adjustments on our end. They've come back to us and we've rebutted things and stuff like that. But yeah, no, it's definitely a regulatory process that's stringent.
So far, I have to say, I haven't found the FDA to be, here are our rules in both directions. They're not so draconian as to do such onerous regulations that you can't get things through. We call that NEPA.
Yeah.
The FDA takes what's called the least burdensome approach. They're willing to listen.
Yeah.
You can discuss things. But most of their rules make sense.
Yeah, it does. Yeah.
It doesn't really bother me so much.
Yeah.
When you go through this process with them, they come back and you get to discuss it. And so far, every time, because it's been in reverse, where they prove me wrong.
Yeah.
When they do that, it's like you keep educating.
Yeah, exactly. But it makes you feel like you have a better, you know that you're putting something out there that is high quality and it's monitored, and it's great. Yeah, there's guidelines and there's guardrails. Yeah, yeah.
But because this is, like what you said, it is help. It is help. So it's nice to have that.
Yeah.
Create a standardization as far as A-bar.
And that's where the trust comes in, right? Because then, I mean, and I think a lot of people don't realize that. And so if you see an organization that has their AI FDA cleared, I mean, their guidelines were, to his point, are valid and good and important, and it sets the bar for people to making sure that the quality is out there before they release it. So good, it's huge.
Thank you.
No, thank you guys.
Appreciate it.
I love it. No, the interaction is great. The interaction is great. Any of y'all have any questions, any additional questions or anything? Yeah. Just ultrasound right now. Yeah, our main focus, it's like you're going to do something good. If you're going to do something great, yeah, focus on that and then expand from there. So like right now, focus is on fetus. We do recognize certain maternal structures, but remember I was talking about that we have some AI initiatives for placenta accreta, things like that. Looking at mom, even like endometriosis. So those are some future enhancements that we'll continue to expand, but focused on ultrasound specifically. So, and of course now you have 3D 4D ultrasound. So this is AI evaluation on 2D images. So the more people start to use 3D, I mean, we have maternal fetal medicine doctors out there now doing full anatomy scans in 3D. So now you got to retrain models on 3D volumes. So, which is interesting. So. Mm-hmm. Yeah. Yep. So so that's the nice thing about being with Samsung. So we have those data sets within Samsung that we can evaluate off of. So. Mm-hmm. So. But well, thank you guys. I appreciate y'all coming. Appreciate y'all joining, and appreciate the conversation. It's been great.